And also, thank you to the rapper from last night's party because I had a great time watching him. It was a treat as I rolled off the plane. I have worked as a speaker and a consultant for Quest Medical, and I do have intellectual property interests. Oh, he's gonna kill me. Perfusion school graduation, 2001, where I met my husband. We did a little bit of traveling after graduating, but we finally grounded ourselves in Atlanta. We actually managed to start a family with our busy perfusion schedules, but we did have to figure out how we were gonna raise 2 kids. Lucky for us, our parents are awesome, and they left their homes in Ohio and Nevada to come and be nearby in Atlanta. When I say nearby, I mean my in-laws live about 10 minutes away in Buckhead, and my parents are directly across the street. So my kids in the morning walk out the front door, down one set of steps, across the street, and into my parents' house. And I can't leave out that occasionally a Filipino meal will show up on my doorstep. And if one of us is working and the other one gets called in, my dad walks back across the street and the kids usually stay in bed. It's awesome. Our support system just kept growing, and my brother and his family joined us, along with my 3 cousins and their families, and my aunt, her husband, and my other cousin. And this is my aunt that everyone says I look the most like of my 5 aunts. It's my roots in Atlanta, our roots in Atlanta, that led me to Wellstar. I've been with Wellstar now for 12 years, and I've been pumping cases alongside Dr. William Cooper for 15. He is the medical director of CT surgery at Wellstar, and more importantly, is an incredible leader. Believe it or not, he's also a lieutenant colonel in the Army and just returned back from deployment in Kuwait 2 weeks ago. So we're thrilled that he's back, happy to have him back safe. He sets the bar very high. Every patient is a VIP is something that he likes to say, and that culture and that mentality absolutely carries it over into how we care for our patients and how we give our cardioplegia. Gonna give you just a little background as to how we got started and why we decided to make a change. I'll talk about the method and the formula and a little bit about communication. And lastly, I have a surprise. It's as much for you as it is for me, so stay tuned. I've used this slide every time I've talked about KBC because this is literally how it all got started. I was pumping a mini mitral. Midway through the case, Dr. Cooper looks up and just says, "Let's try single dosing." And I immediately responded with, "Let's do it without the crystalloid. We have the MPS." So that got the ball rolling, and I'm sure, like most of your centers, a lot of your centers, we looked to Del Nido for some guidelines. Del Nido was developed in the 90s for pediatrics. Potassium is the arrest agent. It uses bicarb, lidocaine, mag sulfate, and mannitol as the other components. Excuse me. And lidocaine is a superstar here. Given its half-life of 1.5 to 2 hours, it lends itself to that long, sustained, quiet arrest. Our goal was then to eliminate the crystalloid, and we had blood as a buffer and carrier, so we no longer needed the bicarb. The result is a solution that provides a long, sustained arrest, but with the patient's own blood. Is this a big deal? We think so. The bottom is a picture of microplegia. It represents what you see in the myocardium. The top picture is a 4-to-1 formula with just 200 mLs of crystalloid given. If we're giving our patients a liter, what would that look like? With the KBC method, our patients receive an average of 51 cc's per case. The additive component comes to us prepared in-house by pharmacy in a 60 cc syringe. It's refrigerated and expires after 7 days. Obviously, you can't do any of this without the MPS, and I am a huge fan, obviously, of the MPS. I've been using it now for all of my 17 years of perfusion. And I joke that if I ever job search that I would filter based on who had the MPS. It is the only machine on the market that allows us to treat each patient individually while simultaneously catering to our surgeon's needs, which we all know is really hard. We customize everything else we do in the OR. Why wouldn't we customize cardioplegia? With any method, the MPS gives us this ability, and it is the key to the methodology of KBC. We manually load our additive pouch with the pharmacy syringe in the arrest pouch with concentrated potassium, both of which we still can pull out of the Omnicell. And of course, we turn our setting to all blood. Formula in place, how do we protect the adult heart? The KBC method uses a 3-part strategy. In addition to the induction dose, it offers a dosing assessment and a reanimation dose. The induction dose is weight-based, 15 mils per kilogram. We give a minimum of 1 liter and a maximum of 1,500. It's delivered cold, and the additive and arrest settings are both 21. Keep it simple. A 1 liter dose at these settings delivers approximately 2.5 grams of mannitol, 1.6 grams of mag sulfate, 100 milligrams of lidocaine, and 21 milliequivalents of potassium chloride. The second part of the dosing assessment is the dosing assessment, which we like to use as our guide, if you will. We do this assessment every 60 minutes or with activity. If we want to give a redose, we evaluate 2 things: the patient's potassium level and the estimated remaining arrest time, or that's the nice way of saying how much longer is the clamp going to be on. Because this is a long arresting type cardioplegia, giving a full dose is assumed to arrest the heart for upwards of an hour, and it will do just that. Here's where the flexibility of the MPS becomes integral. If the remaining arrest time is estimated to be under an hour, you have the option to vary your additive or turn it off. If there's no activity, give minimal. The patient's potassium level determines what the arrest setting will be. At Wellstar, if it's greater than 5.5, we let the surgeon know, and we turn the potassium off in the next dose. The assessment is important to provide accountability and an individualized protocol. We recommend always giving the reanimation dose. The reanimation dose consists of 400 mils, given antigrade at a temperature of 33 to 36 degrees. There's no potassium, but it does have a variable additive setting. The goal here is to avoid giving too much excess drug within an hour of cross-clamp removal. If we've allowed an hour or more for the last dose to wear off, we give a full setting of additive. If it's been less than 30 minutes, we'll give a warm blood only dose with no additive, and if it's somewhere in between, our setting's 10. We do have a couple of procedure-specific adaptations that we've had success with. A lot of people over the last couple of years have asked us what we do with cabbages and what we do with short cross-clamp times. And in full disclosure, we do most of our cabbages warm beating or off pump. But when we do cross-clamp a cabbage, we give the usual induction dose, a cold blood dose down the veins to test flow, and if our surgeon wants to give an exceptionally long vein dose, maybe over 200 mils, we'll turn the settings on at low, and we give the reanimation dose. For a shorter cross-clamp time, same induction dose, and if a subsequent dose is needed, which it almost never is, we'll give it at low to no settings. And again, the reanimation dose. So communication is very important, and like it or not, we have to talk to each other. And I joke with my surgeons about this. When using a new protocol, you have to be especially communicative With KBC, it's no different. As perfusionists, I took this picture yesterday. As perfusionists, it's part of our job to provide the information. We don't get to make the calls, but we need to be there to provide the information so that the surgeon can make the calls. So we're always letting them know if we see any noted EKG activity. Again, if the patient's potassium level is above 5.5, how long it's been since the last dose, and we really, really help guide the additive and arrest settings. The way it works in our OR now that we've had so much experience is the surgeon lets us know if he wants to give a dose, we determine what the settings are going to be. We also have to ask the right questions. We have the cheat camera in the light above the field, so we a lot of times know where we are, but if we don't, we ask where we are in the procedure. We always verify our delivery route. Is it one coronary, or are we flowing down both? And confirm adequate distribution and arrest. The surgeon's role is first and foremost to communicate. This is another one that's harder than you think. But any change in procedure that's going to alter the clamp time is useful information. Excessive collateral flow that may be washing out the heart. And this last one is, in my experience, not a problem for them, whether or not the heart is empty. And I like to also give my surgeons a hard time that it never hurts to throw the perfusions to complement every now and then, and sometimes it even might help your drainage. So it's just a little tip. I want to address this phrase just briefly, comfort dosing. It's one of the tendencies we see a lot with these long arresting type cardioplegias. My definition for it is with no activity, just in case. And we have to be careful because we have that lidocaine in there, and it can definitely take us out of our comfort zone to wait 60 minutes or more without dosing. But truly, this is where the magic happens. If asked to give a comfort dose, I'm always going through the steps of the dosing assessment. Is there activity? What's the potassium level? And how long until the clamp comes off? Lastly, I have data. I got this yesterday. So I'm so happy to have it to share with all of you. It's a retrospective review of about 1,400 patients. This first slide is broken up by approach, open and minimally invasive, and then the second column is first cardiovascular surgery, first time redo, second time redo, and third time redo. For, every slide from here on out is going to be first cardiovascular surgery procedures. So you can see we do about 21% open AVRs, 11% AVR cabbages, and the other category is about 44% of our open procedures. And the procedures that fall into the others are our most complex procedures. So anything that doesn't fall into a standard STS category, for us it's our David 5 hemi-arch repairs, David 5 total arches, cabbage, double valve cabbages, and we're doing some really, really big complex cases, and a lot of them, as you can see here. Also, 42% of our minimally invasive procedures are MV repairs. This slide is broken up by age and gender. Pink, of course, for males. You guys awake? Okay. Pink for females, blue for males. And it's obvious that we have an older population. The bulk of our open procedures are between 60 and 79, and a ton in the 70 to 79 year-old range. In the minimally invasive cases, we're seeing a lot of 60 to 69-year-olds, but an older, sicker population, just like we all thought. This is a BMI chart. Red is, I don't think you could probably read that. Red is morbidly obese, orange is obese, yellow is overweight, and then green are normal and underweight. Again, it's a testament to the high level of acuity that we're seeing at Wellstar. The majority are obese to morbidly obese, or overweight to morbidly obese. And Higher BMIs have higher rates of hypertension, diabetes, pulmonary vascular disease, and the list goes on and on. Obesity is a significant risk factor for and contributor to increased morbidity and mortality. Wanted to just show you this graph on an article. If you combine high BMI and older age, your mortality rate just climbs and climbs. This graph is a bypass and cross clamp time. So our circ arrest cases are taking about 160 minutes. AVR, MVRs, we're at about, can almost barely read that, 100 minutes. So I think our surgeons generally are on the faster side. And then this slide is drugs at discharge, and we have the gold bar is amiodarone, and the reddish-orange bars are antiarrhythmics, and we have very few going home on antiarrhythmics. And 30% of our MVR cabbages are going home on amiodarone. Here, the pink bar is ICU time. Purple is length of surgery to discharge, and then the gray represents length of stay, admit to discharge. It was interesting. I wanted to dig a little deeper into our ICU times and what our practice is like at Wellstar, whether we tend to keep patients longer in the ICU and then they don't spend a lot of time on the floor, or vice versa. And the response kind of across the board was that we're bursting at the seams at Wellstar. We don't have enough beds. So our patients are spending a lot of time in the ICU waiting for beds and sometimes getting discharged right from the ICU. So I think this reflects some of the length of ICU times here. Post-op renal events, our open repairs, 8% was 15% on our circ arrest cases. And these are the open repair replacement are all our MVRs and AVRs, and then the lower three are minimally invasive. Post-op cardiac events, our AFib rates are here. AFib rates range from about 12 to 35% in this group of patients. Normal's about 35 to 45%. So we're doing well there. I know that's a lot of questions or the information that people like to know about this plege especially. And then post-op mortality. I mean, in our other category, our biggest category, it's 3.7%. Circ arrest cases are 9.4%. And STS risk scores tell us that our older, overweight, high BMI patients are the highest risk for mortality. So it's been 5 years we've been given this formula, over 2,200 patients, and we're always evolving. I was doing a mini mitral yesterday, and the surgeon at 20 minutes wanted to redose just out of the norm. And I knew he wasn't far. He's very quick. He wasn't far from taking the cross clamp off. My last K was 3.5, so I gave just a little bit of potassium. I didn't give any additive because I knew the reanimation dose was right around the corner. And the patient came back beautifully. This is the desired method for all cardiac patients at Wellstar. We use it for all comers. We don't stock anything else. It's the only cardioplegia we have. Speaking of cardiac patients, I just wanted to tell you about my all-time favorite patient that came through Kennestone last October. It was a CABG 5 MVR on a patient that we thought needed a transplant. It was the worst disease, Dr. Cooper said, he's ever seen, and we all know CT surgeons are not at all dramatic, so I took that to heart. Regardless, this very, very sick heart received the KBC method and had a great outcome, and this patient happened to be my aunt. Sometimes our work and our passion and our personal lives collide, and in this case, it was a really, really happy ending. So I'm going to play this little snippet for you. It has nothing to do with anything other than this is what happens when the children of two perfusions get your phone.
And two.
Try that one more time.
This is Lily calling to tell you the CVOR schedule for November 8th, 2017. There will be 3 cases and two surgeons, and Dr. Cooper will be on call, and we need you as soon as possible. Thank you. Bye.
As soon as possible, everybody. Okay. Thank you.